questions have been sent ahead, and one of the questions has to do with swallowing. So I'll start with that one. Right. There's really, where was that? I saw there was, oh yeah. When you feel like you're having more trouble swallowing your food, should you have a swallowing study, or is it better to see a GI doctor? Do I need a prescription from a neurologist doctor for that? Now, swallowing difficulties are very common in Parkinson's disease. And it's something that can occur usually later on in the illness. And people can choke on the food. And what I usually do is when people admit, especially the caregiver notices it more, but sometimes the patient too, that they're occasionally having trouble swallowing food and occasionally having difficulty to an extreme that they cough a lot while they're eating. I usually arrange for an evaluation by a swallowing expert at our facility or at any local facility near you, and I order a swallowing evaluation. The people who do this also do speech therapy, so speech and swallowing evaluations kind of go hand in hand. A more significant swallowing evaluation is done, it's done in this way. You're given a barium loaded food to swallow, and it's videoed. And they look at the mechanism of swallowing, and they can see what phases of swallowing are most involved. Based on that analysis, they'll make recommendations as to what you should do when you eat, what to avoid, to cut the foods in small amounts, to be careful with liquids, how to sit upright. So they coach you and give you advice on all the things you should do. Typically, you're encouraged to take small bites, take your time, sip in between if you're having problems, sip with fluids, in between if you're having problems getting the solid foods down. Oftentimes they'll recommend a pureed diet if it's really severe. Sometimes if you choke on liquids, they add thicket to it. It's a powder. It makes it either a nectar consistency, so you can swallow it better, or it can be even a honey consistency. And sometimes it can be even a jello consistency. Yeah. So there's all that advice that is given after you have a formal swallowing evaluation. And that happens, I do that quite a lot with my patients as they begin to have advanced illness. And swallowing often does not get better by increasing levodopa, carbidopa, or adding dopamine agonists, because it's usually the automatic component, the smooth muscle component, that is involved. Although it's such a complicated process, the swallowing mechanism involves some automatic function and some voluntary function. The same with the bladder and the bowel, which is another question. So the beginning of the gastrointestinal system is in your mouth, the end of it is in your rear end, right? And the whole GI system gets involved in Parkinson's disease. So that's the second. So how do you get a referral? You don't need your neurologist to write that referral. It could be your primary care doctor. You can just mention to your primary care doctor or the neurologist that I'm having problems with swallowing, and they would refer you to for a swallowing evaluation. It's done usually in the context of also speech evaluation, or it can be just focused swallowing evaluation. Now, what about constipation? That's the other common thing. And both swallowing and constipation reflect the dysfunction or abnormal function of the autonomic nervous system. That's what I mean, the involuntary nervous system. Things that occur without you having any control for the most part. For example, your blood pressure, your heart rate, etc. Now, if you're a yogi and studied this a long time, you can meditate and cause your heart rate to go up or go down. You can do all kinds of things. You get control over your autonomic nervous system, but it takes a lot of practice. But here's the point I want to make, though. These are autonomic functions. There's a certain amount of control at the beginning and end of these things. So chewing is voluntary, but once you get the food past a certain point, automatically there's all these mechanisms that take place that you have very little control over. The same with going to the bathroom. You get to a point where everything moves automatically, but you have control over the sphincter. You can relax it and defecate, or you can relax it and urinate. Typically, it's the automatic part that you lose control of, but eventually, even the volitional part, you can lose control of. But that's very complicated. In any case, a gastroenterologist, a GI doc, isn't necessary in the beginning. The question was, what should I do about constipation? So, plenty of fluids, fiber in the diet, fruits and vegetables. There are some things that promote very good regular bowel movements, and that is exercise. And if you're capable of it, doing sit-ups is good, but just walking, moving the abdominal muscles helps move the intestines automatically. So staying active is important. There's a material that you can add. You can soften the stool with Metamucil. It's over the counter. You can take prune juice, eat prunes. Miralax is something also you can get over the counter or by prescription, and that is called an osmotic laxative. It draws fluid into the intestine, and it creates more bulk and softer stool. And so there's all those things you can do for constipation. Now, how does that relate to the Parkinson's disease? Well, it turns out that process that involves the brain, the accumulation of these abnormal proteins called Lewy bodies, affect the nervous system of the gut. They affect the autonomic nervous system. In fact, they can find Lewy bodies all along the intestine. It's called the myenteric plexus. It's a nerve network. Autonomic nerves involved in moving the gut, creating the peristalsis that moves the digestive process. And Lewy bodies accumulate there so that there's a disturbance of the natural movement of the gut. And it occurs to various extents in people. Some people have it very severe, some people have it very mild. It's like in the general population, even without Parkinson's disease. Some people are prone to constipation compared to others. I think a lot of it has to do with diet and activity, but some of it is probably genetic as well. Okay, and I'll go back to the other questions. We started off with the gut during lunchtime. Now we'll go into the thinking part. This is actually an important question. It's the first one. Do all patients qualify for deep brain stimulation, which is a neurosurgical procedure for Parkinson's disease? And when is the best time to have it done? Well, no, not all patients qualify for deep brain stimulation. And there's certain criteria that should be met for a person to even think or to be accepted for deep brain stimulation. It's not such a benign procedure. It really involves making a burr hole through the skull and putting in a wire and leaving that wire permanently into the brain, and the other end of the wire goes under the scalp, under the skin, into a pacemaker, just like a cardiac pacemaker. So it's not such a benign procedure. It's done all the time, and the risks depend on the practitioner. Maybe 1% to 2% of the cases have some adverse effect, like bleeding at the site of the seizure or infection. So it's a pretty good chance you won't have any of that. If it's a 2% chance of a bad effect, you have a 98% chance of having a good effect. That's the optimistic view. The pessimistic view is that, well, I could be in that 1 or 2% who have really bad consequences. So who should have deep brain stimulation? First of all, it has to be someone who has already had a very good response to levodopa. In other words, if you have Parkinsonism and the levodopa made things better in terms of slowness and rigidity, and then later on you notice that you're having difficulty with levodopa where it doesn't last as long, and you have what we call complex motor fluctuations where the wearing off occurs more frequently. When you're on, you have excessive involuntary movements or dyskinesias, and you go between on with dyskinesias to off, and do that multiple times throughout the day. And no matter how the doctor adjusts your medication, trying to get everything stable, you still have a rocky road, complex motor fluctuations. Those two criteria qualify for deep brain stimulation. So a response to levodopa in the beginning, And number two, complex motor fluctuations. Those are the complex motor fluctuations that can't be controlled by the doctors adjusting your oral medications. Typically, when I have patients like that, I like to use Nupro to get the dopamine agonist delivered continuously, try to smooth out the There's usually ways to decrease the intensity of the motor fluctuations and keep people away from surgery. So that's my main goal as a physician and a pharmacologist. But a lot of practitioners in the community, as soon as they encounter this problem, they say, well, I'm going to have a neurosurgical consultation because you responded to levodopa. That means, yes, you'd benefit from the deep brain stimulation. And yes, you have complex motor fluctuations. It's the extent of those complex motor fluctuations and how hard someone has tried to smooth them out that I guess differentiates me from others, is that I try my best to smooth out those responses before I send you over to a surgeon. So what does a surgeon and his partner? The surgeon never works alone. He needs another neurologist. And what they'll do is have you come into the clinic without any medicine on board. They'll say, come in the morning and don't take levodopa, carbidopa, or dopamine agonist. Take your last dose in the evening and that's it. And then when you come in the morning, you're completely off of all medicine. So when you come in, you're going to be a little miserable because you should be off. And they give you a trial dose of levodopa. They'll examine you and see how much rigidity and slowness. You should be at your worst. They give you a trial dose of levodopa, carbidopa, and examine you an hour, 2 hours, 3 hours after. And they see if you have a 30% improvement in your slowness and rigidity using the standard rating scale, you qualify. That means you are dopa responsive, and they don't know if you're having complex motor fluctuations, but the neurologist knows because he sent you there because of that. But many neurosurgeons don't care. They just want to say, oh, your neurologist sent you, he must think you're a good candidate. And as I say, the really good candidates are those that have complex motor fluctuations, because those are the ones that get the most benefit from it. Where do they put the electrode? They put it into a region of brain called the subthalamic nucleus. For various conditions, they target different parts of the brain. For example, people with essential tremor, they target higher up an area in the thalamus. For Parkinson's disease, it's just above the substantia nigra. And there are two sides. So the left subthalamic nucleus is involved in treatment of the right-sided symptoms, and the right controls the left. So in some patients, the biggest problem is on one side. They'll only do one side to treat. In some people, they'll do bilateral. The downside of doing bilateral at once is that oftentimes people lose their voice. Their voice becomes very soft. It happens normally in Parkinson's disease anyway, but I had a lawyer who depended on his voice, and he became almost mute from the deep brain stimulation. It's one of the adverse effects of bilateral stimulation in one setting. Typically, they'll stage it, do one side, and then months later, maybe a year later, do the other side. A lot of people, to hasten it, they'll just do both at the same time. After it's in, they don't, by the way, start up the battery start up the program right away. They let it settle in, and then they turn it on and adjust it. They can adjust current, intensity, and the exact site on the electrode to deliver current. So it works really dramatically well for these complex motor fluctuations. If you tune it up a certain amount, you'll get worse dyskinesias. Turn it down, the dyskinesias go away. Turn it down too much, and you're rigid. So it can be tuned, and that's the beauty of the deep brain stimulator. In people with complex motor fluctuations, you can tune the delivery of the electricity to a specific effect if it's properly placed. The biggest issue of when it doesn't work, there are two main reasons the deep brain stimulation won't work. Number one is they never had a response to levodopa to begin with, that this is not Parkinson's disease. So people with atypical Parkinson's disease, where the problem is not in the lack of dopamine, but downstream of dopamine. The way I like to tell people, it's a key and a lock. The key is dopamine, the lock is the striatum with dopamine receptors. And in Parkinson's disease, you lose the key, you give levodopa, and you can open the lock and walk. So people with Parkinson's disease just lack a key. People with the downstream Parkinsonism, they have a problem with the lock. So all the keys I try to open the door with, I still can't move. Well, those people that never had a response to levodopa, they look like Parkinson's disease. They have slowness, rigidity, gait difficulties. Don't respond to levodopa. So they say, well, would surgery help? No, it won't. But many people will have the surgery. They used to, until it was learned that it really is only helpful for people that have Parkinson's disease. I'm talking about deep brain stimulation of the subthalamic nucleus. Now, there are many other movement disorders that benefit. For example, essential tremor, but it's a different target. Or dystonia, which is abnormal postures due to sustained contractions of muscles, like this. It's not Parkinson's disease, and they benefit from stimulation of another region. So, but people with a Parkinson's syndrome must have a response to levodopa in order to qualify and benefit from deep brain stimulation. So the second reason they may not respond, they respond to levodopa, the electrodes put in, but it's not working. It's usually the target is off. It's a very precise target, and sometimes it has to be removed and reinserted at a later time. Okay. What medication? Oh, I should tell you a little bit more about the surgery. So it really helps slowness and rigidity in a great way, and some people can actually decrease the amount of levodopa they take. They'll have less off periods. They'll certainly can have less dyskinesias. The only thing it won't help is speech and kind of axial features. So walking will still be a problem, and falling will be a problem. So don't think of deep brain stimulation as a solution for your gait and balance problem. It won't. In fact, it won't have any effect on that, other than it'll have an effect to the extent that your walking is due to stiffness and slowness, then that will improve. But oftentimes the problem in Parkinson's disease, when you get beyond stage 3, is the loss of postural reflexes and the tendency to fall and no sense of stability, and that is not improved by deep brain stimulation. There is a new target, a new region that they're exploring called the PPN. It's a mouthful, it's pedunculopontine nucleus. It's in between the substantia nigra and a little bit deeper. And that in Toronto and in Gainesville, they've reported several cases of DBS, deep brain stimulation of the PPN, just to improve gait and balance. So there may be in the future a DBS procedure for gait and balance problems. Right now it's not. It's a bit risky. It's a little deeper. You can imagine having 3 electrodes in place. This is a midline structure. You don't need 2 of those for the gait and balance. It seems to be a midline phenomenon. This is actually a common question I get. Does Parkinson's disease affect your vision? Yes, it does. And initially we used to think that the vision was affected by the drugs used to treat Parkinson's disease, especially the drugs used to treat tremor called Artane or Cogentin or trihexyphenidyl, because they kind of block the adjustment of the lens to near vision, so people would have blurry vision on those drugs. But then, even without those drugs, people will say, I have a hard time reading and it's all blurry, or I see double. Those are the common things. Hard time reading and seeing double are very, very common. So the hard time reading is due to the difficulty in scanning a page with your eyes. And you know what's responsible for eye scanning? Are 6 muscles that control each eye. A total of 12 muscles are involved in mobility of the eye. And those muscles are the same kind of muscle that move your arms and legs. They're called skeletal muscle, striatal muscle. They're not smooth muscle like for the gut and bladder. Smooth muscle is involved in autonomic nervous system function. Skeletal muscle or striated muscle are the muscles involved in moving your skeleton and moving your eyes. So those you have voluntary control over your eye movements. You can look in all directions. Now, what happens is that there's rigidity of muscles in Parkinson's disease, and it's always asymmetrical. One side is more rigid than the other. Always is, if it's Parkinson's disease. If it's something else, it may be symmetrical. And so the rigidity of one set of eye muscles is greater than another set of eye muscles. And so it becomes difficult to scan because of the rigidity, so the pursuit across a page, instead of being smooth, goes in little steps, cogwheeling. And there tends to be a fatigue with reading, and because of, if the asymmetry of the rigidity is severe enough, you'll always have one eye slightly exoverted or exotropic. So you'll have two images, double vision. So I've sent a lot of patients in my lifetime to neuro-ophthalmologists. These are doctors who are neurologists and ophthalmologists, and they assess very carefully visual fields and eye movements, and they can make lenses for you to kind of correct the double vision. But in Parkinson's disease, it's not a good idea, because that double vision is eliminated when the dopamine is working just right and the muscles are relaxed. In other words, they're not so rigid. So if the double vision and blurred vision is intermittent, related to timing of dosage, then it's not worth having those corrective lenses for double vision. So it is somewhat of a problem in some patients less of a problem. Typically people will say my vision is blurred or I have double vision, and those are the people I'll usually refer to a neuro-ophthalmologist to let them do a careful evaluation. There's another aspect of vision that's very important, that's an early sign, really early, and that is problems with contrast sensitivity. Now when you get your eyes tested for acuity, so get your lenses, get a prescription for reading glasses, or just for glasses in general, usually have letters, and they can tell you if you have 20/20, 20/30, etc. You can have normal 20/20 vision as a Parkinson patient, but if you're given a different test for visual acuity, it's a contrast sensitivity test, you cannot do so well. And how contrast sensitivity works, it looks kind of like those barcodes that they scan in the store. It's a thick black line, white, stripes. Imagine a really thick first line, and each subsequent black line gets thinner and thinner and thinner until they're just very fine lines, black lines interspersed with white lines, until finally it almost turns into a shade of gray. You can't distinguish black fine line from a white fine line. You can in the left part, and so you're asked in a contrast sensitivity evaluation to see where you last see a separation between a black and a white stripe and where it becomes gray. People with Parkinson's disease have a hard time with contrast sensitivity. They're way over to the left. They can't see the fine, everything looks a little bit gray looking over at the very fine black and white. And that is because contrast sensitivity, which is one of the first things that happens in the retina when things come in to define sharpness of images before it goes to the brain, involves dopamine neurons in the retina. Now, dopamine neurons are in the retina, and they're in other parts of the brain, but the ones in the retina start degenerating as well. And so one of the early things that happens in vision that patients are completely unaware of, and we were all unaware of it, decrease in contrast sensitivity. And how in practice does it affect you? Well, you might notice it driving at dusk, or I like to say driving in London in the fog at dusk. You wouldn't see a thing, right? Even someone with normal contrast. So your ability to distinguish contrast will be greatly diminished. And in fact, people will notice that. So I don't drive so well when it's just getting twilight, I can't see as well when it's just getting dark. So that's how it might. Although otherwise you can only detect that contrast sensitivity deficit with special eye exam. So I think I covered everything about the eye. One more thing. There's a new kind of biological marker of Parkinson's disease progression as it gets worse gradually over the years. And they have a device that allows you to measure the thickness of the retina. It's optical tomography, just basically like a normal reading thing, and it can, I don't know the physics of it, but it measures the thickness of your retina. And the retina thins out with normal aging, but it thins out very rapidly, much more rapidly in Parkinson's disease patients. And a lot of people believe that you can follow how advanced the illness is by periodically measuring the thickness of the retina. That's a kind of a new area of research that again involves the eye, the retina. So to summarize, there are reasons you can have visual problems. One is the retina itself, which takes light and transforms it into electrical signals. Dopamine is involved in contrast sensitivity at the level of the retina, and that can be abnormal because you lose dopamine neurons. You may not even be aware of any difficulty. But then the other reason for difficulty is that the muscles that move the eye become very rigid, more in one eye than the other, and so you can have double vision or problems with scanning when you read. And the third reason that visual problems can occur is medications. So that's always an important one to consider. How often should a Parkinson patient be seen by his neurologist? Well, in most academic settings, it's usually every 6 months. If there's like a new patient and there's questions about what the true diagnosis is, often sent a very complex patient, you might need to see him a few times, a little quicker, maybe in a month, especially if you're introducing new medicines and trying different things. But typically, maintenance care in Parkinson's disease is every 6 months. Some private practitioners will see patients much more frequently, depending on what the patient wants to do and depending on what the neurologist's office likes to do. But generally, I would say an average, because I ask my colleagues at different medical centers, and generally it's every 6 months. Twice a year is enough to manage quite well a patient. But how do I know when I should move to assisted living community? And how do I know which is best for me? That's difficult for me to know. But here's there's a few questions I ask. If the person is starting to have sufficient difficulty with activities of daily living, that they can't function on their own, that's time. So if it's really, really difficult to get dressed, or even cognitive issues, if you're kind of forgetful about your medications, if your balance is really poor and you're falling a lot, those are times that those are little signals that maybe you should be around people and have an assisted living facility. So those are things that have to be discussed in greater detail than I can do now. And each case you have to deal with individually. This is a question that hadn't been asked for a while, but I guess things are heating up. What will the constitutional amendment on marijuana do for PD patients if it passes? There's a series of questions related to it. Would other drug extracts of marijuana be allowed with this amendment, or will only marijuana in its natural state be allowed? Based on your overall thoughts, what is your position on this amendment? Vote yes or no. Well, first of all, I can't tell you how you should vote. That's up to your, concepts of government, and if you know anything about the history of cannabis, because marijuana is a prejudicial name. It's a slang name that the Mexican workers used in California for the plant that we know as cannabis, which has been used for thousands of years. Now they found even in a mummy from Siberia that was preserved. The mummy was studied and found she had died of breast cancer. And she had a supply of cannabis that she was using to treat herself. So that's interesting, because it is, in the ancient times, it was used as an analgesic, a pain medicine, like opiates were used in other societies. Well, cannabis can relieve pain, and cannabis has been shown in class 1 clinical trials, in other words, double-blind, placebo-controlled trials. Cannabis in various preparations has been shown to alleviate pain that is not alleviated by opiates. So pain of peripheral neuropathies, pain of phantom limb, people who've lost a limb or a digit have this incredible pain. And cannabis really is very helpful. It's probably the only drug that is helpful. When I talk about cannabis, this is the difficult issue, is that it's a complex material. It contains 70 different cannabinoids and terpenes. It's a certain structure. The two that are most studied is THC, which is the component that people believe creates this psychoactive component, the sense of well-being, or what others would say, if you take it in too much, making you high or feel good. And the other is cannabidiol, which modulates the effect of THC. In other words, it kind of blocks a bit some of the THC effect, but also has very evident neuroprotectant and antioxidant effects. The NIH, Dr. Julius Axelrod, actually, who's a Nobel Prize winner, was working with cannabidiol, and he was given a patent by the US government to use cannabidiol, which is a component of the cannabis plant, as a neuroprotective agent antioxidant. Now, why is it then that the FDA, which is part of the Department of, the DEA, which is part of the Department of Justice, and the FDA, consider it Schedule I drug, means it has no medical use, and it's dangerous? And the reason it's in that schedule is political and economic. It has nothing to do with scientific evidence. So what's happening is that state by state, people are recognizing that you can't get the DEA, the Department of Justice, to reschedule marijuana, quote unquote marijuana, because of political economic reasons. I'll tell you more about that in a moment. And so the states, this is the nature of the US, it's always had local government and federal government, and sometimes they clash as to who has the right to do what. And that was the basis of the Civil War, as you remember. And still there are, so gradually there are state by states that are voting on allowing medical marijuana, and then some states are so open-minded about it, they actually allow it to be legal and regulated like alcohol is regulated. And how is alcohol regulated? Well, you can't sell it to minors, you tax it, the taxation benefits whatever the state wants it to benefit. It could be education, could be whatever. Now, who would be opposed to allowing marijuana to be used as a medicine? And would be pharmaceutical companies, because their mantra is you need a pure drug acting on one receptor. And cannabis has too many components. And we don't really understand how it works. So that's one of the opponents officially to the rescheduling of cannabis as a useful medication. But if you look at the literature, and I was asked to prepare a course for by the Florida Medical Association on the medical use of cannabis and what are the appropriate formulations, routes of administration, and dose schedules to be used for various conditions. The conditions for which studies have been done to show it's effective. And I'm not going to get into all those conditions, but as it relates to Parkinson's disease, that's one of the conditions where it's been shown to be helpful in terms of the rigidity and tremor and sense of well-being. So, and the other question is bouts of depression. Well, there are sense of well-being is one of the benefits of cannabis preparations that have THC. Now, I'm going to backtrack about Amendment 2. I'm not going to tell you how to vote, but since Amendment 2 got enough signatures to get on the ballot, the legislature, the state of Florida, and the governor signed very quickly, a few months ago, a compassionate use law for cannabis that is very low in THC. It has to be less than 0.8%. And it's prepared from a strain of cannabis called Charlotte's Web. The reason that was pushed through is, number one, there's been a lot of anecdotes in the media about this strain of cannabis, very rich in cannabidiol, for which there's a patent, the US government, supposedly treats intractable seizures in children with intractable seizures. And Charlotte was one of the cases of intractable epilepsy that was treated with this strain of plant that has very high levels of CBD, cannabidiol, which is an oily-like material that you can concentrate and have it as an oil. And so that was allowed by the state of Florida to be used. And so that the Florida Medical Association knew that I was working, I've written a couple of things about cannabis as a medication, and they asked me to help them for the course, which is going to be mandatory for all healthcare providers, physicians, so they know how to use cannabidiol or a Charlotte's Web. So I reviewed the literature and found there was no really good studies, no really good placebo-controlled, high-quality studies showing that cannabidiol was helpful. Even for epilepsy, what probably happens in epilepsy is that cannabidiol alters the metabolism of the other antiepileptics so that they become more effective. But that's my conclusion from the very scant literature. Nevertheless, even though there's no good literature, they passed it. How could they do that without any scientific rationale based on anecdotal reports? They did it because they want people to say, we don't really need the dangerous stuff that's going to be allowed by Amendment 2, because young people's brains will shrink, people will get into automobile accidents, they're going to start using hard drugs. For each of those points, when I wrote this chapter, the gateway drug in our society is alcohol. Once teenagers start drinking alcohol, they go on to try other things, and that's actually, alcohol accounts for 40,000 deaths in automobile accidents a year, liver disease, neurodegenerative processes, peripheral neuropathy, that's alcohol. How many people have died from cannabis overconsumption? 0. Never been a death due to cannabis intoxication. Now, I won't deny that people who are intoxicated with excessive cannabis can get into auto accidents, so that's going to be something that's important. What about for Parkinson's disease? Well, in the 19th century, now cannabis was used in Indian medicine in India for a few thousand years, or maybe 3,000 years. In China, they found it in a shaman's burial ground. They found amongst his medications a bunch of cannabis seeds. And in the 19th century, when Britain was in India, had conquered India in essence, Dr. O'Shaughnessy was with the British troops. He was a physician assigned to the British troops, and he became aware that cannabis preparations in tinctures were being used for nervous conditions, nervous people with tremulous movements. So when he came back to England, he brought a gallon of what they ended up calling O'Shaughnessy's elixir. It sounds like an alcohol. Well, he had an alcoholic extract of cannabis indica, the Indian cannabis. And it was around 1840. By 1880, I have an old book called Manual of Neurology by William Gower. He was the leading neurologist in the United Kingdom. This book was published in London in 1888, and it has several pages describing paralysis agitans, Parkinson's disease, and what were the treatments. The two principal treatments in the 19th century were belladonna alkaloids, because they didn't know how to make artane or cogentin, so they just concentrated the belladonna plant, which contains the medicines we use now for tremor, called artane or trihexyphenidyl. Those are medicines that actually can cause hallucinations and confusion if you take too high a dose, as a pure drug or in the plant. Either way, it can cause a lot of toxicity. The one that caused a lot less toxicity, and was recommended, was the cannabis indica in tincture of alcohol. They recommended adding it to tea and taking it 3 times a day for the treatment of rigidity and tremor. So it was in use, and all of the European countries had cannabis indica preparations in the pharmacopoeia, which is a listing of all medicines for all these conditions. In 1937, there was the Marijuana Tax Act. I'm not going to get into all the history, but they began to try to suppress the use of cannabis indica. And so physicians had to apply for permission and pay an extra tax in order to prescribe cannabis, but you didn't have to do that for other drugs. So gradually people stopped prescribing cannabis indica. It was only in 1970, in the Nixon administration, that was reacting to the excessive use of hallucinogens by our society, our youth, that the Drug Control Act was passed, and there they put marijuana, quote unquote. They didn't even use the real name. Marijuana, didn't even define what constituents of marijuana. Schedule I drug. What is a schedule? What were its partners in Schedule I? Heroin, LSD. Even cocaine is not a Schedule I because it's used for local anesthesia. ENT doctors use it to anesthetize your nose. But marijuana Schedule I means it's either because it's dangerous, tremendous abuse liability, and has no medical application. But if you look at the literature, it's amazing how much has been done. The US is lagging behind the European countries and Asian countries in doing these studies because they don't have such draconian laws about cannabis. So number one that's important is it was in Israel that Dr. Meshulam identified the cannabis receptor. In other words, our brains, the reason that these drugs from the plant work is that our brains are loaded with these protein receptors that interact with phytocannabinoids. These are the cannabis compounds that interact with the brain. And guess what? The dopaminergic neurons of the nigrostriatal system and the mesolimbic system are modulated. They have little receptors for cannabinoids. And as they go down, the cannabinoid receptors go down. So one of the ways that cannabis works in Parkinson's disease is to, why did I say modulates dopamine? If there's underactivity of dopamine, the cannabis increases release of it. If there's overactivity, it dampens it. That's how it modulates. It does it for dopamine, glutamate, and a number of other neurotransmitters. So we know that from research. So Dr. Meshulam of Israel was the first to find the receptor. And he said, well, if there's a receptor, there must be an endogenous cannabis compound. I mean, why would we have a receptor in the brain? And it turned out there was. He named it anandamide. And it's a molecule that acts just like the plant THC, tetrahydrocannabinol. So there's a close affinity, like all these plants that affect our central nervous system act on receptors that are, how can I say, that interact with our own endogenous plant-like neurotransmitters. The best example is opiates. And this, when I did my PhD in the 1970s, it was an exciting time because the endogenous opiate receptor was discovered. And we not only had receptors for morphine in our brain, especially around pain receptor areas, around a number of regions of the brain had opiate receptors. And then that led for search for where's the endogenous, the brain's own morphine. Well, those are called enkephalins and endorphins. Now we know that you can turn on endorphins and enkephalins under various conditions. If you're in a running and pushing yourself, and there's a release of endorphins that help you deal with the pain, and you get addicted to the pain. To the exercise, for example. So this runner's high is due to upregulation of your own morphine. You don't need to take morphine to get that runner's high. In other words, it's just part of the brain's regulatory system. And so plants that interact with these systems shed light on our own endogenous system. So the plant cannabinoids have really illuminated a lot about the function of our own brain cannabinoids. And there's a number of drugs that are being developed that will affect your brain's production of cannabinoids. And that's what the drug companies really want to have a handle on. And they worry that if there's exogenous plants, materials that people can easily access, people won't want to go to the doctor to get a prescription. Well, the way I see it is that cannabis preparations have to be very carefully regulated. They have to be defined. So each strain of plant has to have two indices, the amount of THC, the amount of cannabidiol. And the proportion of the two determines what the therapeutic benefit will be. And the delivery system has to be defined for a specific condition. So there's a lot that has to be done. So let's say Amendment 2 is passed. Believe me, it's not going to help Parkinson patients right away, because once Amendment 2 is passed, Then there's all these regulations that the state has to put up, has to approve. And that's going to take quite a while because most people in the legislature don't like this. Because the lobbyists for the drug companies, and who's the other beneficiary of the current drug laws? Just remember that we have the highest concentration of prisoners in the world, and more than half of them are there because of cannabis law. And many of them are Hispanics and African American, and women. Turns out a lot of women are busted for cannabis, and they serve time in the federal penitentiaries. So what happens if someone is driving in Florida and they have 2 ounces of cannabis in their car? And he happens to be driving a really nice car, a Ferrari. He's pulled over for speeding. The state trooper sees he's got cannabis. He arrests him, and guess what? He can keep that Ferrari. He can keep any money in that car, and goes to the police. The local police force gets to keep it. And what happens is a tremendous effort by the police to keep the laws as they are because they benefit. It supplements their income. It supplements their ability to, maintain their police forces. Or if they go into a drug bust into a home, well, there's these illicit substances. You have 5 plants growing in your plant. Well, they can take your home, any of your property. That's the current drug law. Now, if cannabis is removed from those legal restrictions, a lot of people will benefit, a lot of people will not. Certainly the police won't benefit. They would in the sense is they can really go after the real criminals now. And secondly, the prison system, I don't know if you know this, is primarily private. And the more prisoners they have, the more the corporate profit. So to empty the prisons of these people who've broken the marijuana laws is going to be very difficult for the pharmaceutical companies, the police, and the prison executives. Who would benefit? I think people would benefit. Especially young people whose career is damaged because they happen to be busted for having a little too much pot in with them. I just don't think it's appropriate. And how did marijuana get such a bad name? A little bit of history. I'm telling you this so you have a smarter way of voting, so you'll be able to figure out for yourself. But the prohibition of alcohol, remember that big experiment? And it really happened because people were really abusing alcohol in the United States. And there was a temperance movement, mostly by women, the teetotaler movement. And they were eventually successful in lobbying and getting Congress to pass the prohibition of alcohol. What did that do? That was, right after World War II, World War I, all the way to 1932. So over 10 years of prohibition. And there was enforcers, that federal government, the revenuers, right, that would go and try to break any illicit alcohol production, the distills in Kentucky, the smuggling into Boston or into Florida of rum, the going after the mafia, the traffickers of alcohol. Many prominent citizens made their fortune through smuggling. I've always heard that Joseph Kennedy's family, who later gave birth to John Kennedy, and they made their initial amount of money by smuggling into Boston. Smuggling whiskey from Ireland into Boston because they had to keep the speakeasies going. So what happened with all of these federal police officers, the equivalent of the Drug Enforcement Agency, but this was against alcohol, when prohibition was seen to be a big failure because the amount of drinking was just as much as ever, and people were drinking contaminated stuff. Bathtub gin that was toxic, made people blind. There was a tremendous disrespect for the law, tremendous amount of black market money, and mafioso growth. So it was repealed. But it was repealed at the beginning of the Great Depression. So what was going to happen to all of these federal employees that went after the mafia, went after the distilleries? They were going to be unemployed. So Anslinger, who was in charge of that, decided we're going to go after other drugs that are destroying our society. And they needed a big propaganda effort. So he said, well, we'll go after this so-called marijuana that the Mexican workers in San Diego and LA are using. And we'll go after this cocaine that the blacks are using in the inner cities, and that's what they focused on. And that was the beginning of prohibition against marijuana and making it, you've heard of, you should see this film, you could probably get it on YouTube, Reefer Madness. It was just the most, I thought it was a satire, but it was real. It was a propaganda film made to show Americans how dangerous marijuana was. It made you psychotic, it made you suicidal, it made you homicidal. And so that's the kind of thing, is political, economic, that put marijuana into Schedule 1. Has nothing to do with science, nothing to do with biomedicine, nothing to do with patient suffering. So it's up to you to decide, you know. My view is that people were really informed. If people were really informed, they wouldn't have allowed it to be Schedule 1 in the first place. But I think even if Amendment 2 is passed, that's why I'm a cynic. I may not even vote for either Amendment 1 or 2 because I don't think it's going to be important. What's really important is the federal government reclassifying this. Because if the federal government reclassifies it even to 2 or 3, like Valium and Librium, I could at least do studies with it. It doesn't matter what the state says about it. I don't care if it comes from Florida or from Florida dispensaries. It'll be available one way or another as long as one can obtain it for research. And I think so much more research has to be done with it, but it's impossible for doing research with cannabis preparations now. Now, the FDA did approve a cannabis preparation, and we still have it. It's called Marinol, and it's used for glaucoma. It's another medical use for cannabis. Increase intraocular pressure is a common cause of blindness. And cannabis can shrink that, decrease that intraocular pressure. And the pure THC is an oily material in a capsule, and that can be prescribed. The problem is it's too powerful. It zonks people out, quote unquote. Makes them very spacey. You can't adjust the dose properly, and the absorption is erratic because it's an oral pill, and it can take an hour and a half to 2 hours to have an effect, and it can linger for a long time. So that form of cannabis can't really be used for Parkinson's disease or various other movement disorders, for the simple reason that a pure THC is not that useful. What turns out to be very important about medications is that sometimes it's a combination of 2 or 3 that works better. We call it the entourage effect. Like cannabidiol with the THC, by the way, is commercially approved in Canada and 23 other countries, called as Sativex, as an oral mucosal spray. It has completely different effects than just pure THC. It actually is what's allowed to be used for pain and muscle spasms in Canada and England. You can write a prescription for it. I can't write a prescription for that here because it's a Schedule 1 drug. There's no it doesn't have medical use. Just read about Sativex. It comes from cannabis sativa, 50% THC, 50% cannabidiol, plus the extract that contains a whole bunch of other compounds. The reason that we, and I know because I studied the history of pharmacology in my training as a pharmacologist, the idea of a drug as being a pure chemical that acts on a single receptor to produce a single response is an illusion. It doesn't ever work that way. But the reason we started thinking along those lines, and that's the basis of modern pharmaceutical drug discovery, is that when methylene blue dye was injected intravenously in the 19th century, and other dyes from the German chemical industry, the dye makers, they noticed that tissue stained, some tissues would stain blue and some tissues didn't. And if you looked at the brain, you see only some brain cells would be blue and others wouldn't. So they began to look at where was the dye or the drug. It's a very simple anthracene chemical bound to something in that cell. And that something they called a receptor. That was the birth of the drug receptor hypothesis and concept for drug discovery. And they found that if they changed the chemical structure just slightly of that methylene blue, they could get it to stain other types of cells. And so that was the beginning of drug receptor pharmacology. Now it turns out, to give it an example of dopamine, we know dopamine acts on dopamine receptors in the striatum and is responsible for automatic execution of learned movements. And if you don't have dopamine, you have a hard time moving. But it turns out dopamine doesn't just act on the receptor called the D2 receptor. There are 5 types of dopamine receptors, and they have different affinities for dopamine. So you can make a single drug acts on a constellation of receptors, and sometimes if it's at a high dose, it'll act on receptors that aren't even their own type. They'll act on serotonin receptors, for example. So there's another example of why we're starting to shift into the concept of a drug and its entourage. Like cannabis is the best example of that, because in the literature research I found that the combination of cannabis with various amounts of different cannabinoids has very different effects that may be beneficial for one condition and not the other. That's why I think it's going to be very important for the future of drug development to figure out what are the best combinations of these drugs and to study them. As a clinician, I think they're safe enough that we could do it in people a lot quicker than we could for other drugs. So I think that's enough, and I'll let you decide how to vote. Anyway, only registered Florida voters can vote. I don't know how many of you come from up north. I think it's going to be very close, just like the governor's race. I didn't bring a fan with me. Okay, I have one more just to get us off the cannabis thing. The reason I'm talking so much about it is not just that this election is coming up, that we just had a meeting at the university. There's a benefactor that wants to start a cannabis research center. She says, even if this amendment doesn't pass, there's clearly a sea wave of change regarding this plan. That everyone is recognizing the medicinal benefits that could be derived from. Even the drug companies, don't believe me, they're all ready to go with this. And so we got together with 12 individuals, botanists, drug discovery people. I was the only neurologist. And we're going to probably form a cannabis research center at the university. And hopefully we'll get seed money from this philanthropist and start doing the research. Some of it will be in animals, some will be cell culture based, some of it will be kind of botanical genetic engineering, to try to get the right strains. So, for example, we need to be able to get strains that are really high in cannabidiol, like Charlotte's Web, because those will be able to be used next year. And I'd be willing, and in fact, Dr. Meshulam of Israel just published a great review on cannabidiol. Cannabidiol, quote, doesn't make you high, end quote. And it's true, and has no psychoactive effect, but it modulates the psychoactive effect of the part that does make you high. And when they're together, it's a fantastic combination. So you don't get too high, but you get some of the neuroprotective effects. And the THC is what carries the punch in terms of neurotransmission modulation. So it's a THC component of the cannabis that allows dopamine to function better, that allows you to feel better. Cannabidiol has absolutely no effect on Parkinson's disease. I reviewed the literature that no effect on rigidity. What it does is protect cells from oxidative stress. So it's a very potent antioxidant. To change the channel here, is it normal for Parkinson's patients to have bouts of depression and sad feelings? I think it's normal for life, not only Parkinson's disease, but we're talking about serious clinical depression. Yeah, it's more common in Parkinson's disease than the average population of the same age. And the reason is, well, let me give you some data. About 50% of patients with Parkinson's disease, this is done in retrospective studies of medical records, had diagnosis of depression and treated with antidepressants before they developed the first signs of Parkinson's disease. So oftentimes, depression can antedate the diagnosis of Parkinson's disease. Secondly, people who already have Parkinson's disease, 70 to 80% are diagnosed as also having depression. and are taking antidepressants along with their dopamine replacement drugs. Now, why is that? And it's because this disorder is not just a single dopamine transmitter loss. Like we always like to simplify things, but like I was saying about the cannabis, it's much more complex. There's a loss of norepinephrine, serotonin, and changes in acetylcholine transmission. But mostly the three neurotransmitters are depleted: serotonin, norepinephrine, and dopamine. When you deplete dopamine, serotonin, and norepinephrine, that creates a perception of depression, loss of initiative, feeling fatigued, sadness, no desire to do the things you used to like to do. And the antidepressants increase levels of serotonin and norepinephrine. The first class of antidepressants were the tricyclic antidepressants that increase all three of these monoamines. Those are amitriptyline and doxepin. But then the new class, which became very popular, only increased serotonin. Those are the serotonin reuptake inhibitors, selective serotonin reuptake inhibitors. First of the class was Prozac. Now we have about 10 different ones: Celexa, Paxil, Lexapro, that kind of drug. And they work to produce an improvement in mood, alleviate the depression by increasing the levels of serotonin at the synapse. So yes, that was the answer to the question. Yeah, we all suffer from depression. It's a normal kind of rhythm, a mood rhythm, I would say. Although there's some people that are eternally optimistic. Let's see. There's one more question that I think is important. What vitamin supplements are safe to take with Parkinson's disease? I think they're all safe. You should say, what doses should I avoid? Well, I'm going to get right on to coenzyme Q10, because that's one I've been promoting for years because of preliminary studies, pilot studies with 80 patients, showed that coenzyme Q10 at high doses, much higher than would normally be considered safe, but it's an experimental therapy, 1,200, 2,400, 3,200 milligrams of coenzyme Q10, right? The initial study showed that if you had 1,200 milligrams or more, you could slow the rate of progression of Parkinson's disease. So that led to a huge study where some individuals took up to 3,200 milligrams of coenzyme Q10. You know that would be an extremely expensive thing to take. You know, many of you who take coenzyme Q10 know how much it costs. And the prices come down at Walmart. But the studies came out, had absolutely no effect. So people ask me, how much of the coenzyme Q10? I said, don't take the high doses. 300 milligrams a day has been shown to be good for general health, especially cardiac health, for your peripheral vasculature. It's a good antioxidant. Just don't take more than 800 milligrams a day. Same with vitamin E. We did a huge study. Why are we so interested in these antioxidants? Because one of the common themes of aging is that as we get older, there's an accumulation of oxyradicals that react with proteins, DNA, and lipids, and we become rusted, so to speak, just like iron reacts with oxygen to make a machine that doesn't work well unless you keep it oiled. And the antioxidants scavenge the free radicals. And so the idea was that if we can take antioxidants at a high enough level early enough in our lives, we'll be well-oiled machines. Turns out, not true. It just doesn't seem to work. It was the first big study of high-dose vitamin E. Was 2,000 units a day, international unit. Now, normally they say no more than 1,000 units a day is safe. But we wanted to push it to really high. We want to make sure that all the neurons are well-oiled. In a sense, it's that. They're very oily, they react with oxygen, free oxygen, and so it prevents the dangerous effects of these free radicals that are produced with normal respiration. With normal oxygen intake, reacting that oxygen with the fuel, you generate exhaust. That exhaust contains free radicals. If you can scavenge it, catalytic converter, so to speak, you'll have less damage to the machinery of the cells. And it turned out that 2,000 units a day for 5 years had no effect on slowing progression. So then they said, well, that's not such a good one because it doesn't really get into the brain properly. let's do coenzyme Q10, which really goes right to the heart of mitochondria. It's a normal antioxidant within mitochondria, right where the fuel is being burned. And so that was the rationale, and there was all kinds of, always great animal data to support these research, otherwise FDA wouldn't allow it. You need to show the concept is correct, that it works in animals, and then you can go to humans. Then when you finally do the huge study after many years and millions of dollars, it's very disappointing. I got similar news for my Huntington's disease patients who were given really high doses. It took 4 years, and study was cut off even earlier. It didn't go the full 5 years. It didn't have any impact on the progression of Huntington's disease. The problem is that we're dealing with kind of an end part of the disease pathogenesis. I like to say it this way. I like simple analogies. The bullet that causes the injury, we don't know what's firing that bullet. What really fires it, the person that pulls the trigger, the gun. But if you wear a bulletproof vest, maybe you'll have less injuries. So what we do with antitoxins is wear these bulletproof vests. But it turns out that that bullet isn't really what's causing the harm. It's some other stuff that's being released, like the vapors by firing the gun are really the toxic element. We don't really know in Parkinson's disease what the true initial trigger is. We have ideas now that are different. We know that oxygen radicals are involved in the final demise of neurons. But we don't know what some of the earlier steps are. We know that Lewy bodies accumulate, but by the time you see Lewy bodies, it's kind of late. Those are kind of tombstones of cells. And so we're trying to figure out why is it that this alpha-synuclein, which is essential for normal function, when it starts polymerizing, when it's just oligomers, it hasn't formed the clump yet, that's the toxic thing. That's what's so-called vapor that I talked about, whatever it is. So until we get to the earlier steps in the pathogenesis, we won't really have a good treatment to really stop the disease. So with these antioxidants, they were being studied with the goal of slowing the progression, so people will stay the same year in and year out. They don't progress. And we've not been successful with that approach. There's also medicines that would prevent cell death, called anti-apoptotic agents. One of them was minocycline, turned out to be a tetracycline. Well, that was not helpful in slowing progression. I think what may slow progression and maybe cure it would be vaccines that recognize the early alpha-synuclein oligomers and bind them and prevent them from forming Lewy bodies. That would be a cure. So in the future, we could vaccinate people against Parkinson's disease. That's what I would say. That's early on. That's something early on in the illness. Not wait till the bullets are flying and you put on your bulletproof vest. Yeah, it could help you. It could help you. I'd wear a bulletproof vest if there are bullets all over the place. But I would like to get to where the bullets are coming from and stop that. You know, that's the only solution. So I think I'll end here.